My name is Natalia, and I am the practice manager here at the Center for Developmental Psychiatry. Today, I'm sitting here with Dr. Jason Dean, the founder of our wonderful practice, and he's just going to be telling us a little bit more about his approach, the philosophy of the practice, and what makes us unique. So, Dr. Dean, thank you so much for joining me here today. To start, can you just tell us a little bit about the practice and what makes it unique?
We have a practice of four psychiatrists. Three of us are child psychiatrists, and one is an adult psychiatrist. I think what makes us unique is that we try to really get a deeper perspective on what's going on. So people come in to see us, obviously, with symptoms of inattention, let's say, or anger, behavioral issues, anxiety, depression, things like that, which, of course, we're going to try to treat. But what we often find is that symptoms are just the tip of the iceberg. So beneath the surface, there are usually things going on like social, emotional, developmental issues, underlying self-esteem issues, things like that. Maybe there's some bullying going on in school. So we try to really understand more than just what's going on the surface to make a diagnosis. We try to understand really what's going on underneath the hood, so to speak. And that's really important because if I hear a story of a child, I can just determine what the diagnosis is and what the medication would be. But really, what I'm trying to convey when doing an evaluation is, should you take a medication, right? So the easy part is to talk about what medication it would be. It's much harder to actually convey in all of the complexity how to think through in detail whether or not to actually start a medication. And I think that's the most important part because you can just write a prescription for Prozac, let's say, and give it to somebody, but then they're sitting there wondering, should I actually give this medication to my child? And a lot of people who come in to see us are, I think, appropriately hesitant about medicating their child. And we take that really seriously. And so we're really looking at the underlying development and we're trying to understand on a developmental trajectory, where is this child going? Because obviously we care how a child, let's say at 5, is feeling, but we care much more at the age of 25, who is that person going to actually be? And so we can actually get a pretty good sense most of the time where this path is leading. And then we can kind of really explain to parents in a lot of detail what's causing the symptoms and then where things will go. And then they can make a personal decision. And we really don't push medication. That's not our agenda. Our agenda is not to like automatically prescribe medication, but it's an incredible tool that we have found to be really, really impactful, sometimes totally transformational for people. So our goal is really to explain our recommendations in the context of a much deeper understanding of what's going on, and then to kind of guide parents through the decision about whether or not to actually pursue medication or other treatments. We also, I think what makes us unique is that we also offer psychotherapy, which back in the old days, that was very common. Most psychiatrists did therapy, but nowadays most psychiatrists do not. So if people come to us and they don't have a therapist yet and they want to see us for psychotherapy, we can do that. If they have another therapist, we then collaborate with the therapist. But the point is that even if we're just doing the medication, we see things like through the lens of a therapist. And that allows us also to, I think, to not overprescribe, let's say, because we have other tools in the toolkit, so to speak. So those are some of the ways that make us unique.
Dr. Dean, how do you know when it's the right time for parents to bring in their child to be seen?
Yeah, that's a great question. A lot of people wonder about that, I think. I think a lot of people see the idea of seeing a psychiatrist as really the last resort. They don't really want to come see a psychiatrist. Um, I think of three main domains when I'm thinking about treatment, whether that's therapy or medication. The first one is subjective distress. So, for instance, you have a child who's having panic attacks, let's say, where they just say that they feel horrible, or they're crying all the time, or they're angry all the time, and you can tell that obviously they're in distress. That's one good reason. The second one is impaired functioning. So, for instance, a child needs to function at home with family, needs to do their homework, needs to go to school and function that way, needs to function socially. These are all the different domains of functioning. So, let's say a child is so anxious that they're not able to socialize, appropriately, or they're so angry that they're not able to do their homework and they're being defiant and stuff like that. So that's the second thing. The third thing, I think this is the most important, and this is really what the evaluation gets at, looking at the developmental trajectory. So a child really needs to be able to do all the things that a child does so that they can move forward developmentally. A lot of children get stuck, unfortunately, in one of the different areas and they're not progressing. That might be a little bit harder for parents to see. Sometimes parents can see that, but I would say that if a child is really in a lot of distress or a child is impaired in any of the areas of functioning, that would be a good reason. I also think that if people are unsure whether medication could be helpful, a lot of people, like for instance, have heard that medication for ADHD could be really, really impactful. That's one area. If anybody thinks their child might have ADHD, that's actually an area where medication can have a really, really, really big impact. And that's actually like one of the easiest things for us to treat. But that could be sometimes hard to pick up on. So if a child's having a lot of difficulty in school and it's not clear why, and there's a question, could this be ADHD or is it anxiety? Um, I also think another good area is to understand the diagnosis, understand what's really going on. So, um, psychiatrists are often able to kind of figure out the diagnosis, even if some other people can't. So sometimes, like a therapist might send a patient to us, for instance, to get diagnostic clarification. So to figure out what's really happening. So especially in a complicated area, like a lot of people will start with a pediatrician, let's say, and they're wondering like, should I just go to my pediatrician and maybe get some medication? And a lot of people do that, but if it's more complicated and you think maybe there's some other things going on, like learning disabilities or ADHD or um, maybe some complex like underlying social emotional developmental issues or self-esteem issues, things like that. Getting that really good evaluation is important because whether or not you use medication, at least you know what's going on. It's almost like you're in like a dark room, and you're like walking and you're bumping into all the furniture and then you just turn the light on. So it's not fixing everything instantly, but at least you kind of can see what's going on. you know so my goal in doing the evaluation is like to look for everything. So I'm looking for everything, and then I kind of spell out for the family, what's really going on, at least what I think is going on, and then come up with a plan. The other thing is that even if we're not going to actually implement every part of the plan, I think of myself as a quarterback. So I'm kind of helping families coordinate all the different services. We have a lot of connections. Actually, you're involved very heavily in our connections with the community, but we have a lot of connections with other clinicians and services in the community. So even if it's not the kind of thing that I personally would do, I can still help create the entire comprehensive plan and then help guide the parents through carrying out that plan. And if people are interested in medication, on the spectrum of psychiatrists in terms of, uh, I prescribe medication all the time, but I really don't push medication, and I really don't see medication as like the only thing or like the biggest fix. So it's really about kind of offering medication when it's appropriate, but then really helping people see that big picture and help them kind of walk through because navigating the mental health system is really, really, really hard. Um, and so we help with that basically. So those are some of the things I would say.
Okay, and what about for parents who they're a little bit worried because they don't think that their child's going to participate or, feel comfortable enough to come in for a session? How do you deal with a situation like that?
That's a good question. Well, obviously it depends on the situation, but I would say that I make it pretty relaxed, like a lot of adults I think are expecting children to come sit down and just talk to me the way that we're talking now or the way that an adult would talk, but that's really not, even the healthiest child is not able to express like that in words how they're feeling. The evaluations are done mostly for younger kids, at least mostly through play, drawing pictures, things like that. And so most kids come in, sometimes they're a little bit nervous, but by the end, usually they're like smiling and they had a fun time. And then they say they want to come back because um, especially with younger children, the evaluation is mostly through observation. Obviously, I talk to them and I ask them questions, but a child who's having, let's say, a lot of defiant behavior because they're very angry at their parents and they think their parents, prefer their sibling over them, something like that. They're not going to come in and not going to say that to me in words. What they would do is like draw pictures, tell stories. There's a whole way of kind of getting them to kind of express some of these things through play. Yeah, so they don't even usually realize that I'm taking a look at all of that, but through looking at those symbolic things like the drawings and the storytelling, I'm actually able to get a window into kind of the underlying psychology of what's going on. Um, and that's really, when we do an evaluation, it's a 4-session evaluation. So we do a parent session and then we do 2 child sessions on separate days, and then we do a final feedback. And part of why we do the 2 different sessions with the child is to really get that much deeper kind of comprehensive understanding of what's going on. But the child's not usually aware of that. And so, not to mention that when I start with a child or a teenager, I always just start by asking them what they're good at, what their interests are. And, I had a teacher many years ago who used to say, story first, symptom second. So, I like to start with the idea of person first, symptom second, So my goal first is just like, who is this child? Who is this person in front of me? Can I bond with them? The other thing is the most important thing, in my opinion, is really creating rapport with people. You could be the most brilliant psychiatrist, and the first people don't like you and people don't trust you and they don't feel connected to you, it's not going to really help. So when a child comes in, especially if they have anxiety and especially if I can tell when they come in, they're nervous, it's really very chill in the beginning, just trying to get to know them. I have a basketball hoop here, so I can like play basketball with kids if they're interested, stuff like that. So that's what I would say.
Okay, great. And Dr. Dean, can you tell us why you decided to become a psychiatrist?
That's a very good question. Um, so I always knew I wanted to be a doctor. I did not always know that I wanted to be a psychiatrist or a child psychiatrist. Actually, before going to medical school, I started reading psychology books. I started reading Freud, actually, Sigmund Freud, and I got really interested in psychoanalytic theory, psychodynamic theory. And then I went to medical school and I wasn't really sure. I actually thought I wanted to be a cardiologist for a while or actually like a neurosurgeon, actually. Which what I do now is actually similar in some ways, but like the total opposite end of the spectrum. But I really was very fascinated in understanding people, understanding what makes people tick and what makes people do what they do and feel the way that they feel. But I think really one of the most important things is that um, for better, for worse, psychiatric things, psychological things really kind of like pierce to the core of who a person is. You know what I mean? So for instance, a person could have a heart issue and they're still the same person, but now they have a heart issue. But when someone has depression, someone has anxiety, someone has ADHD, these things really almost get into like who you are as a person and how you experience yourself. Um, I think that's part of why people have such a hard time sometimes coming in to see a psychiatrist and taking medication because the idea of these things being almost part of you leaves people with a lot of conflicted feelings, I think. But I really like helping people on that level. I think it's one of the most profound ways to actually help people because you're connecting with people when they're the most vulnerable and dealing with issues that really are very foundational, very intense issues. And I appreciate that people trust me in that way and don't take that for granted. And yeah, I find it very gratifying, very fulfilling to be able to intervene on that level.
Dr. Dean, can you tell us about the four-step evaluation?
So our evaluations for children are 4 sessions. The first session is a parent session. These are all 45 minutes. The first session is a parent session. And then we do 2 individual sessions with the child on 2 different days. And then there's a final feedback session. So the initial parent session, that's to get all the background information. For instance, if this has been going on for 6 months, that's very different than 6 years. And then even the healthiest children, they can't usually tell you their developmental history. They can't tell you really a lot of times in the big picture what's going on. So the parent session is really to understand the history and also like the broader context of everything that's going on with the child. And then the 2 sessions with the child, the main goal really is to build rapport. In addition to obviously doing an evaluation to understand what's going on, we're trying to really connect with the child. So that's part of why we do 2 sessions. Another reason why we do two is because a lot of people are very anxious when they're coming in. And so let's say we're evaluating for something like autism spectrum disorder, and we're looking at for eye contact and how withdrawn the person is, or if they're really interacting. So they could just be very anxious because they're meeting a new person. But the most important reason why we do two is because we're trying to get much far past just the diagnosis and just the symptoms. So usually 1 session, you can kind of just figure out the diagnosis and what medication you might recommend. But we're really trying to get a much deeper understanding of who this person is as a person, the developing personality of a child, let's say, or a teenager, and to really get a very good sense of how the symptoms are actually impacting development. And then in that final feedback session, If the child is, let's say, 13 or 14 and older, then they usually join. And if they're younger, then it's just with the parents. And the reason why we have the older teenagers join is because at that age, I really think they should take ownership over their treatment. But also, a lot of teenagers and parents are not on the same page. So I really like to have a conversation. The feedback session is much more of a conversation than me just like talking at people, and telling them. So obviously, I share all my thoughts. I go through all the different treatment options. But my goal is to really make sure that this resonates with families and that it makes sense and that we're all on the same page. Um, and my goal for the feedback session is to present all the different options of treatment, whether that's therapy, whether that's medication. And even within the medication, there's usually different options of medications that you could try. We talk about all the potential side effects of the medications. And then I help families really make personalized decisions for their family and for their children. And that really depends. Like for instance, some people will come in, and in the parent session, I like to get like a sense of how people are thinking about medication. So some people come in and say, yeah, if medicine would help my child, that's totally fine. And other people would say medicine is like a last resort. And so in the end, when I'm giving the recommendations, I can explain to people how strongly I'm recommending it, what the different options are, and try to help them kind of think through the process. So I think of it as kind of laying out the landscape of all the options with all the pros and cons, and also helping tailor that to the specific preferences of those parents. And then they choose. With an adult, it's the same process, except we don't do that parent session. So it's just two diagnostic interviews with an adult, and then a 45-minute feedback session at the end. So that's our process.
I know that we offer in-person sessions as well as telehealth. Can you talk about, the benefits of both?
Well, I think the biggest benefit of telehealth is the convenience. So I think a lot of people find that to be very, very helpful, especially if they don't live close to our office. So our office is in Teaneck. So we do have in-person in Teaneck, but we do telehealth across the entire state. We also do telehealth in other states as well, in New York, in Connecticut, Massachusetts, Pennsylvania. So telehealth allows us to open up access to a lot of people, across the entire state of New Jersey and these other states. But a lot of people have very busy schedules. They may get home from school at a certain time, and by the time they would get to our office, um, we wouldn't be able to see them at that time or something like that. And so they just sometimes just go into their car and do a telehealth visit. You know what I mean? Um, I think that telehealth is equally effective. I have many patients that I've been seeing for weekly therapy or even twice a week therapy for years, just on Zoom. And I've either never met them in person or I met them in person a couple times, and they've benefited very significantly. So I really do believe very strongly in telehealth, but we also have in-person availability. I think in person, a lot of people wonder, like, oh, can you really get a sense of somebody if they're not in person, And I think the answer is yes, for sure. Um, I think that for some people, like if the evaluation is for, let's say, autism spectrum disorder, that's probably better in person. Um, I think some kids, they've tried telehealth, it hasn't worked. I'm doing a session with them and I see the flashing red and blue lights because they're just like playing video games and stuff like that. So there are certain children, if they have really, really bad ADHD and they're not going to be able to sit and focus, then in person could be better. But we also offer, a free consultation to people who are wondering about whether telehealth will work for them. And we can set up a free 15-minute consultation just to meet with the doctor over Zoom, and then people can check. So I think that both are great. It just depends on what people are looking for.
Dr. Dean, what would you say to people who are considering going out of network versus in network?
So our practice is out of network, which means that we don't accept insurance. What we do is we give patients a receipt called a super bill that has all the information on it, and then they can submit that to their insurance. And if they have something called out of network coverage, which a lot of people do, they'll get reimbursed by the insurance company afterwards. And so a lot of our patients get reimbursed up to like 60%, 80%, something like that. Um, I think the reason to consider an out-of-network practice like ours is that it gives us total flexibility to offer the treatment that we think is going to be the most helpful. So in the insurance model, the insurance company can actually control and dictate what we do. So, we do these 4-session evaluations in the beginning, and then our follow-ups are usually, let's say, 45 minutes once a month, something like that. In the beginning, as we're starting medication, we might meet every 2 weeks. We can offer psychotherapy, whether it's every week or every 2 weeks or every month, ongoing. Insurance companies would almost definitely not pay a psychiatrist to do all of those things. You know, you can do a few sessions, and insurance companies will just say that they're not going to cover it anymore. And so, the main reason that we're doing it is that we can actually provide the right kind of evaluations and the right kind of treatment that's really going to help people. So in thinking through it, I mean, obviously it's more expensive usually to go out of network. But I would really think of it as an investment, because these issues, if they're not understood correctly in the beginning, they're not addressed correctly, it's kind of just like kicking the can down the road. And even if it's expensive now and you could go in network and save some money, but if the problem's not really diagnosed correctly and it's not addressed early, it becomes much bigger usually later on. And these, especially if they're like, if the issues are impacting development, you could have, let's say, a kid who's having defiant behavior eventually becomes a teenager who's depressed or suicidal or things like that. Those problems become much bigger and actually much more expensive too down the road. These issues, as they go on, get entrenched more deeply in how a child or teenager views themselves. And so when you intervene early, you can often prevent a lot of damage from happening rather than waiting a number of years and then trying to unwind all of that. So I would really look at it as an investment, basically. People come to us because they really want to understand really what's going on in a much deeper way, and they want to do something about it now, even if it's, very time intensive and it's more expensive upfront. Because the way I look at it is, if you do a number of months or maybe a year or two of like really, really good treatment, and then you just fix the problem, then your child will just thrive and you don't have to worry about it. So that's how I would look at the difference.
Dr. Dean, can you tell us about what follow-ups look like once someone's become a patient?
Often when we start a medication, we like to see people back in about 2 weeks. And that's because in the first couple of weeks, there could be side effects sometimes that we want to monitor for. We want to see that the medication's working. In the first number of weeks and month or two, that's when the most changes happen because we're optimizing things. We're seeing how people respond to the medication. And, we don't take it lightly that we're medicating people, medicating children, where their brains are still developing, and we have to kind of, just make sure that everything's on track. So we'll usually meet back in about 2 weeks, usually for about 45 minutes. And then after that, it depends on what somebody's looking for. So if we're doing therapy, that would be usually once a week or twice a week. If it's just medication, then it depends if they want to also have some like parent guidance, things like that. If they want to meet with us every 2 weeks to kind of really just, make sure everything's going, as well as possible, then we could do that. Or we could end up meeting like once a month, basically, for 45 minutes. And the follow-ups are doing a few things. First of all, we want to make sure there's no side effects. We want to make sure that the medications are working. Often when you're doing things like treating ADHD, you end up making a bunch of different adjustments to the dose. Sometimes you're increasing the dose, you're adding, other things. And so by meeting a little bit more frequently, it allows us to optimize things much more quickly rather than just waiting and having it take, many months. The other thing is we're trying to build a relationship with people, and this is really important because a lot of people will ask like, why do we have to meet again? Nothing's changed. But I think this is actually really important. The way I see it is that we're not just providing medication, we're not just like gatekeepers to medication. We're actually providing a relationship. We're providing an ongoing evaluation of what's going on, beneath the surface. And we're trying to really bond with people, so that when things go wrong, unfortunately they do, sometimes, then we're really well positioned to kind of step in and intervene and not just like reflexively change the medication. If you only see people 20 minutes every 3 months and then they come in a crisis, the only thing you can really do is just medicate them, or change their medication. This allows us to really say, well, wait a second, I've been meeting with you once a month for 45 minutes for the last 6 months. I really know you. Like, let's talk about what's going on. And often you can actually uncover that something's happening, they're being bullied or whatever. And you can intervene in a way other than just medication, or with medication, but you just have so much more information, that you'll make a much more, I think, accurate decision.
Can you describe your approach to treatment and how you collaborate with other providers like therapists or pediatricians in schools?
So, I think medication is really important, but it's really only a very small piece of the puzzle. So the other things that are really important, the things you're mentioning, psychotherapy, and how things are going in school. So if a child doesn't have a therapist and I'm doing the therapy, then I might want to collaborate with their school, especially if they're having issues in school, talk to the teachers and things like that. If they have a different psychotherapist, then we set up collaboration meetings. So I'll talk to them for like, 10, 15 minutes, sometimes before they come to see me, sometimes after, and then every number of months, just to kind of make sure that everything's on track. And that's really important because, I see the difference when I'm doing the therapy myself versus when I'm not. If you're doing the therapy, you just have so much more information about, the person and the child and what's going on. So if I'm not doing the therapy myself, then I at least want to speak to the therapist who does have all the information to get the bigger picture about what's going on.
How can patients or families get most out of their care with you?
So I think it depends what people are looking for. Like some people come in and they want the all hands on deck approach. So the all hands on deck is therapy once a week or twice a week, and monthly parent sessions, and medication when it's appropriate. And that's kind of, that's the most that I can do. I think of what I do as kind of like a spectrum of services. You know what I mean? Like some people come in just for an evaluation and they don't even necessarily want treatment or need treatment. They just want to know like what's going on. That's one end. Then other people will see me for medication, and then they might follow up with me, like I was saying before, maybe 45 minutes once a month, something like that. Um, when I'm doing that, then I'm providing the medication, which is really helpful. And those monthly sessions, that's much more than just talking about the medication and side effects. If you're doing 45 minutes once a month, I really treat that like a psychotherapy session, actually. So people get quite a bit from that. And I kind of think of it as medication management on steroids. It's like, uh, it's medication management, but I'm also doing quite a bit of therapy. And I think that's really important. And then there's that, when I'm actually doing weekly psychotherapy. Um, so I think that one of the most important things is really the follow-up. Like we start off, we do this evaluation, we come up with a plan, that's great. But then what I find is that consistent follow-up really leads to the best results. People like I understand because it's expensive, or it can be expensive. And so people want to kind of not follow up regularly. But I think that when people follow up really consistently, that's when we can get the best results because we want to make sure that things start moving in the right direction and then really move in the right direction consistently without kind of slipping backwards, and so that's what I would say. But I would say that if people do these monthly sessions, these monthly like 45-minute therapy sessions together with the medication, I think that's really helpful.
Dr. Dean, can you explain your approach to medication?
So I think a medication is really a very important tool, but it has to be taken, understood in context. So the first thing I'll say is that a lot of people are worried that if they put their child on medication or they themselves go on medication, that it's going to be forever. So the first thing I'll say is that medication is not forever. It's not written in stone. You're not really committing to anything. Most of the medications we use, you do not become dependent on them. Dependent means that your body needs it and you can't stop it. We try incredibly hard not to use medications like that. So in the vast majority of cases, the medicines we're using, they're relatively easy to stop. I've really never had a time when a patient was not able to get off of a medication. Um, so that's the first thing I'll say. A lot of people also worry that medication will change their child's personality or their own personality. Um, that's not the goal at all. The goal is to take whatever's going on and to lower the intensity. So you should still be the same person. Your child will be the same person. Like people worry that it's going to take away the spark, their child's spark or something. They're going to become like zombies. That's not at all the goal. Um, and that's not at all what generally happens. And if there's any change that people don't like, you could just stop the medication. So that's not, you're not committing to like changing your child in any long-term way. The other thing I would say is that I mean, I try not to prescribe medication unless it's really needed. You know, for adults or children, but for children more so because a child's brain is still developing. And so if we're adding a medication into the mix, we're altering the chemistry of the brain as they're developing. And these things are safe. I mean, we've been using these medications for a long time, and we have long-term studies showing that they're safe. Um, but you don't want to be cavalier about, intervening and prescribing a medication for someone whose brain is still developing. So the younger they are, the more benefit I want to see, basically, or in other words, the issue has to be a bigger issue to warrant using a medication the younger they are. Um, but I think of really three main domains. So, in terms of whether or not to prescribe medication, the first one is subjective distress. So, if you have a child who is having tantrums all the time, is depressed, is suicidal, is harming themselves, something like that. So that's a very high level of distress. That's a good reason, even if they're functioning beautifully, but if they're having a lot of distress, that's a good reason to use the medicine. The other area is impaired functioning. So a child has to function at home and at school and with friends. And, if depression, let's say, is stopping them from going to school or doing their schoolwork, and then that would be impaired functioning. And the third one, and this is the most important, I think, is the developmental trajectory. So in the evaluation, I'm trying to get much deeper than just the symptoms to really try to see, how is this child developing in terms of social emotional development? And if I see that the symptoms are interfering with that, that's a really big red flag to me because when symptoms are impairing development, they become much, much, much bigger problems, and children will end up falling farther behind. And so those are the three areas that I look at. When I do use medications, I try to use just the fewest number of medications as possible. So I always say like no medicine is better than any medicine, one medicine is better than two, and I try to use the lowest dose possible. So we typically start at like a very low dose and kind of increase gradually. I also don't just pile on medications. You know what I mean? Like most people are only on one medicine or maybe two medications, something like that. Some psychiatrists will put on like, 6, 7, 8, 9, 10 medications. We don't do something like that. Um, and the other thing is I always look as soon as I start the medication, when am I going to stop the medication? Or how am I like, what are we looking for to stop the medication? So what I often find is that when people come to me, they're really in a rut. And, let's say like defiant behavior, they're so angry that they're acting out, which makes the parents respond in certain ways, which makes them more angry. And it's just this vicious cycle. And a lot of times you just need a medicine to kind of stop the cycle and pull them out of that rut. And then especially if they do therapy, let's say, for maybe 6 months or a year, by the end of that 6 months or a year, they could be a totally different person. And at that point, they don't necessarily need the medication. So every year or two, or sometimes even after just 6 months, I'm already evaluating, should we stop the medication or not? You know? And then if you go off the medication and the symptoms come back, it's just basically the same ongoing decision, over time, is medication warranted or not? So you're not really committed to anything. And if you go off the medicine and the symptoms come back, you can go back on the medicine. But that's really how I approach it. I think it's a really important tool. I think that in combination with psychotherapy, that's really the best. And studies have always found that. So, I prescribe medicine all the time because most people come to see me, you know, either they want medication or it's appropriate. But by no means do I don't push medication. I don't have an agenda to put people on medication. I just want to make it available to people, if it's appropriate and desired.